Hi, I'm Terry Arnold, and welcome to Talk IBC. And I'm especially excited today because there's been a milestone hit recently I would have never thought we'd see in my lifetime. And I have Dr. Wendy Woodward with me, who is the executive director of the Morgan Welch Clinic, who is on the committee to make this wonderful thing happen. And I also have with me for the first time on a podcast, Jennifer Heckert. And Jennifer is a board member up in Ohio and also an IBC sister. So without a lot of further ado, I want to get to talking about the thing at hand, how there is now a code for inflammatory breast cancer. Dr. Wendy Woodward, you were on the committee. Yay. And let's talk about how this happened and what does this mean and what does this not mean?
Sure. Thank you so much for having me. Um, how did it happen? It is an amazing story, I think, because as you know, all of the advocates for IBC for 20, 25, 30 years have all said this is a gap. We need codes for IBC. Why don't we have them? And so I asked the Komen Collaborative leaders specifically because it came up because we said, people asked, what are the gaps? We said, these are the gaps, as they have been, and they were able to do it. So I asked, what made it possible now? Should we have asked in a different way earlier? Did we not find the right path? And some of the things they said are that the timing was really good timing. As you know, there's an IBC score now that we participated in validating with the Dana-Farber, and that is available online from Komen's site. And that is helpful because it demonstrates something really quantifiable, some real progress, some real collaborative progress to the committee that reviews these requests that looks like it's a new time. So that may have contributed. It may also have been helpful that Komen has a team that really understands policy and could give some advice to the team that's involved in the IBC piece about how do you navigate some of these questions, because the process really does involve asking the federal government and asking the teams at CMS, where do these come from? What's the process to put in a request? So that piece, I think, was really helpful as well. And I think also having the collection of clinicians involved who are able to really articulate the difference in treatment that happens because of this also may have been really impactful to CMS, because the need for a code is to drive a different treatment and to be really clear that a different treatment is needed. It may be that some of the data that has come out on the reduction in what's called guideline concordant care, the number of patients who are getting the recommended appropriate treatment, also helps to demonstrate that it's needed. There's what's supposed to be happening isn't happening. And so could this fill a gap? So, it sounded to me like really the time was right, and that having this collaborative of people from around the country, with Komen, who have some existing insight about how some of these government pieces work, made it successful.
I think it's incredible because I was told, and you and I have talked about this before, that we didn't have a code. So we were under tracked. And then unfortunately, so often we're only tracked off death certificates, and not to be morbid, but death certificates don't say, they might say kidney failure or whatever. It may not show all the backstory. And that's not the best way to count. And hopefully people will live a long time. And this is not part of their story at all. But this means a lot to me. But I think this, and one reason I'm so excited Jennifer's here, somebody newer, younger on the scene may not realize the void that was there. So Jennifer, I got together when she visited me recently in Texas, and we have a list of things we want to talk about: what the code means, what it doesn't mean, and how we're going to forward. And I'm going to show you real quick. I'm wearing one. I'm going to hold it up. We had a T-shirt made called "From Invisible to Undeniable" to celebrate this milestone, because when people started writing me about hearing about the code, they were like, I finally feel seen. And the tears of joy. And I thought, wow, this is really meaning something to people. But there's also some misunderstanding. So I'm glad you did it. I'm glad it's here. I do have one question. It's a complicated one, and we could do it later, but about, is it truly an international code or not? There's three codes. So there's one for the disease itself, one right breast, left breast. We can get to that in a minute. But Jennifer, I know you've got particular questions. And so I think it'd be great to talk about. And Wendy, you've seen this document, so you know what's there, and you've made some good edits for us to publish some things to represent what happened on the committee. But I'd kind of like to get into some of the truths and some of the myths about what the code's going to mean.
Perfect.
Wendy, do you want to, or Dr. Woodward, do you want to take it?
Go ahead and let's go through some of the questions you have.
Okay, great. So I want to know what needs to happen next. What do you need as a doctor from us? What can we do to support you, and how can we have the greatest impact with patients?
I think it starts a new journey of awareness. You know, the last 20 years have been like, how do we make people more aware of IBC, get the diagnosis right, all those kinds of things. So now we have this code. People have to know the code is there in order to use it, right? So we've got to make sure that people are aware that they can find the right code, because nothing stops you from coding it as it has been in the past, which is invasive breast cancer of overlapping sites, right? So there's a long list of breast cancer ICD-9 codes, and they are right breast upper inner quadrant, right breast upper outer quadrant, right breast lower, etc., and overlapping sites. And inflammatory breast cancer, because it involves the whole breast, the best thing you could do is to say this is invasive breast cancer of an overlapping site. And you could still put that in today. You could, and when this comes out, it actually goes live October 1st, but you could put that in for the rest of time, and there isn't an audit. I don't think anyone would find it and be like, oh, this was an inflammatory breast cancer. You can make this a little more specific. So we've got to help people be aware that there is a code, and to even ask. And maybe some of that happens in the advocacy community by making patients aware, so they can say, hey, can you be sure that my ICD-10 code is correct for my diagnosis, so that my research is tracked and gets tracked. And we can do the same in our communities and physician practices, and make sure people are aware this is how this should be coded. I do think it'll take a little time, one, for it to go live. I had to do a little research to find out in my own institution, will we have these available the minute they go live October 1st? And what I learned is that we receive sort of an update twice a year. And so it'll depend a little on whether or not, if our update happens right before that, we'd have to wait 6 months for the next one. So we're going to even need to be able to evaluate and look and see, are we going to catch it in this next update, or will it even take another 6 months before we have it?
You know, I want to interrupt real quick here. That's an important thing to think about, because people just think it's going to instantly happen. And I know when I talk to people about IBC and getting to a specialty clinic, they say, oh, well, my doctor goes to all the breast cancer conferences. They all go to the same conferences. Well, IBC is not taught. And so even if they go to the same conferences, it doesn't mean they know that. And the fact that the code update might be delayed is something that was a surprise to me. But also, too, no one tells you there's a new code. That's on the person in the back office, the code person, kind of, isn't it?
Yeah. And it's, you'd be surprised how haphazard it is. Now, to a certain degree, I know all the codes that I use all the time, because that's, you know, that's in my realm. But if you came in and I mean, the ICD-10 includes codes for an extraordinary number of things. Like, I think there's even one if you broke your ankle on the space station. Like, there's a lot of really detailed things. But if you didn't know to look for that, you wouldn't look for it. So if you came in and you have a problem that's not in my realm, but I needed to do something about it, so maybe you did break your ankle, you know, on the space station, I would search the database, and I would first come up with broken bone, and then there's a longer list, and maybe it would be, well, broken left, you know, this particular bone, and then maybe I can find a more specific thing. But it's a little bit dependent on how that search goes. What did you first look for? What are you aware of? I think that breast cancer doctors are going to be very aware of their breast cancer codes, and then whether or not they search to find a new code, if they already know they can type in C50 dot, et cetera, do they find a new code? So some education there would be valuable. You made me think of something about going to the conferences, and I know that you guys go and have a booth at the big conferences.
Yes.
I think advertising this, having handouts, making people aware would be valuable. And just trying to do everything we can at a breast cancer meeting like San Antonio, for example, to make sure that people are aware there's a new code. And we can, it makes me think we should look into where else can we fit that so that people become aware of it. We could maybe even find out would San Antonio do an article on it or something in their thing. In the future, being able to do, if we could get an abstract into San Antonio next year about even a survey, how many people are aware of it, then it's something that would be in the existing data, right? It's something you could look up. It becomes enduring and be like, oh, here's an interesting abstract that people don't know about this code. I didn't know about this code. So we could do some things like that.
So
Taking notes, I'm excited. And you mentioned, and I'll get to you in a minute, Jennifer. When we heard the code came out, first thing I did is stop the presses for all of our presentation materials for San Antonio because we changed everything. And I know Komen will have a booth, they'll be talking about it. But since we are specifically focused on inflammatory with the overlap to triple negative, everything is going to be about that. But I would love to get an abstract survey going and an article too. Okay, Jennifer, what's the next question on your mind?
Well, I had a question for Dr. Woodward. So if for the ladies who are current patients with IBC, so you would encourage them to speak to their oncologist about making sure that
I would. It couldn't hurt to say, hey, do you have access to this code? This just changed. Can you make sure I get coded? And I think in the first 6 or 12 months, what we're going to find is we've all got to wait for our Epic or whatever our electronic health system is to upgrade. And the people may not realize this, but the electronic health record is a thing that you buy and build as an organization, a hospital system. And then periodically you will get updates, you will get pushes from them, but it's not live in the sense that it's constantly connected. And so it's just like if you get your Microsoft Word software and it's if they added a new feature, you won't have it until you upgrade.
And Epic, can you explain what Epic is?
Yes, absolutely. So as a part of the Affordable Care Act, there was a lot of incentive and impetus to move to electronic health records. And the advantage of that is that it should allow places that you might seek care that have the same system to talk to each other so that you actually don't constantly have this fragmented care where your records in one place don't talk to another and those kinds of things. And the largest electronic health record in use in the country is from a company called Epic. But it is not the only one. But the ICD-10 codes are embedded in that search software because you've got to be able to list a diagnosis, you list a problem, you list a diagnosis. If you're going to prescribe something, it's going to be tied to that diagnosis in a very specific way. So if I'm taking care of you as a patient and I'm recommending you see physical therapy so that you can get a lymphedema sleeve, that's not going to be tied to your inflammatory breast cancer diagnosis. That's going to be tied to your diagnosis of post-mastectomy syndrome. So, people have all these specific problems and you want the actual treatments to be tied to the correct diagnosis.
Question before Jennifer gets the next one. Jennifer said, can I go to my doctor and make sure I'm coded right? Will there be room for retrospective recoding? Because that's something people are asking me. They think that we're going to all, like I was diagnosed in 2007, that all get recoded. I think that's highly unlikely, but also
it is a little bit, you could recode it. It won't matter for national data registry pulling because there are these national databases. We are not a country that has a uniform healthcare system where we have one national health database and can say, what did everybody who got this, have? But there are at least two national databases. One's called the NCDB, the National Cancer Database, and one's called SEER, Surveillance, Epidemiology, and Results. And there are different states or programs that participate in this and spend the resources to collect data on the patients coming in and submit it. And so if it's been submitted already, I can, in my system, go back and make an edit. I could recode somebody who was go back into yours and recode it and update it. But it was submitted years ago and it won't get submitted again. So it's not going to change that fact dating because that's a forward moving thing. I've edited a document after I've already submitted the papers or sent it off. So what that could help maybe is in my own institution, do I correctly pull the right patients if I go back and edit them? But it's a little bit piecemeal. So I think it's possible to do it. It may provide individuals some reassurance to know that they're in correctly, but I'm not sure that it changes the bigger picture to go back and do it.
That's some of the myths. So Jennifer, I know you've got a whole list of questions. So
Yeah. So my next question, update medical and nursing school curriculum. Will this be something that's taught to people working or training to be in the medical field?
So there is a lot of, and has been for years, a lot of interest in what can we do to improve the teaching of IBC in any curricula where it would matter. And that still needs to happen, but this doesn't directly relate to that because right now there's not a lot of, in the US, ICD-10 codes are a lot about billing, and there's not a lot of education about billing in medical school, to be honest. And so when you finish all of your training and you get out into the world, and now you need billing and coding education, you usually turn to consultants or to colleagues who already know how to do it. So I'm not sure it'll impact that.
I think that's important because people just think, and again, you don't want to sound like sour grapes because what happens really big is one of the biggest milestones in a long time in the history of
And it'll
IBC.
make a big difference, but it's going to make a difference moving forward, and it won't be overnight. But I think it allows some conversation that'll help people to ask more questions. I hope that if you put in a diagnosis of inflammatory breast cancer, it causes you to be like, wow, that's different. What else do I need to know? Maybe I need to look it up. Maybe I should open the NCCN guidelines and make sure that, I'm up to date. Is it possible that in EPIC, there could be some kind of a cue? You have diagnosed inflammatory breast cancer. Do you know these are the guidelines? Maybe it opens up some opportunities there that we can explore. But it's going to take some time.
Appreciate you saying this because as excited as we are, to me, this is where I say the heavy lifting starts. We have an opportunity now to really do something powerful based off what has happened. Okay, Jennifer, I know you keep looking around because your dog sneaks up behind you, but we are loving it. So don't
It's
let
so
that worry you.
cute.
Everybody on YouTube is going to love your dog.
Yeah,
So cute.
We have an 8-month-old puppy that is crying and never satisfied. So of course he's
That's okay.
Oh,
We
you
can make him
can
a
tell we're
celebrity.
talking about him. He's like, me?
See,
Are you
it's like,
talking about
isn't
me?
that the cutest thing?
Okay, y'all
Super
see him?
cute. Yeah, he's so cute.
Love it. All right.
So what else,
next thing-
Jennifer?
Oh, sorry.
What else?
Okay, the next thing I've got is inform the public. How will this help like patients misdiagnosed, dismissed, raise awareness so people know the signs, how urgent IBC is?
Yeah, I think that's crucial. And so I think one of the things you guys do well is make some, tweetable infographics that are easy to consume, easy to share, all of those kinds of things. And so I think that's going to be really valuable to make sure that all of the charities and programs that are connecting with IBC patients have that kind of content and are just like, hey, this might not have been on your radar, but be sure you get your diagnosis coded correctly as soon as that's possible. So I think that's going to be a big piece.
I think it's a big piece. I think Jennifer's trying to take care of her dog, but so if you just turn off her camera for just a second, she'll be back. But I think it is a big piece because like I said, I think it's very important people understand we are in a place now we can move forward in a really big way and how it's going to impact research. And I think my feedback I've gotten from people, and Dr. Woodward, I'd love your opinion on it, is it's going to be about 5 years we have some really good hard numbers. Do you think that's a fair thing to say?
I think that's a fair thing to say. Yeah, I think there's some estimation in it. How long does it take people to get it? And we can pull it and track it. So that I think will be interesting. But yeah, I do think it's going to take a little bit of time. I think, as you said, it is an opportunity. It's a chance to think about, now that we have it, how do we do that? And something else that maybe we can explore is what cues in the electronic health record could actually be tied to it. And that for sure, I think, is something that an organization like yours can do some exploring and find out. Is there content that could be at the elbow when you click this button? Does it give you some pathway to give you some help? Because that really would make a difference.
Feel like the organizations that made this happen were the right organizations, and they have that structure from policy, can have that. And I think one thing we can bring to the table is we can host some lunch and learns at hospitals or various things that like you've got all these IBC network relationships. Maybe we could do some things there to, because we can do things that other people can't do or don't have time to do or whatever, because you're busy curing
Yeah, it
cancer,
all helps. It's so
and so it
powerful.
all works. Okay, Jennifer, I know there's still more on that list.
Yes, yes, yes. The next is support insurance and policy change.
Yeah, I think that piece is really helpful because when you can pull real data and say, this is the diagnosis, this is the guideline concordant care, is it then possible that the insurance company can say, oh, no, I'm not going to pay for that inappropriate lumpectomy because that's not the appropriate care for this? And not
That's
my
a
area
big
of
one.
expertise, but let's for sure think about, could we begin to ask some people in that space who would know, is this likely to help, and what's needed to make it work?
Is this cancer different in a way that a lumpectomy would be more valuable or important for a patient as compared to another type of breast cancer?
Yeah, for sure. One of the challenges is that if IBC is a disease of the whole breast, and your surgical goal is to remove the cancer, there's not a way to leave the breast behind. There just isn't. And so the appropriate standard recommendation is a mastectomy. It's important that it's not a skin-sparing mastectomy because this is a cancer that involves the skin. And we really want people to understand that that is just the single option. And so, if somebody has this diagnosis from the beginning and then sees someone, particularly in places where you don't get all the team in one place, if you have care in multiple different places or over a timeline, you're meeting a surgeon down the line who never saw it up front, who may not realize, oh, this was inflammatory breast cancer. Now you've had amazing response and it all looks great. And you think, oh, we could do this lumpectomy. But hopefully the fact that that diagnosis was put in correctly would help to guide this and say, well, this isn't typical care for this. Because for sure, the guideline concordant care is start with systemic therapy, make the surgery easier and treat everything that could be circulating around, then do the appropriate surgery, do the modified radical mastectomy, remove the lymph nodes, because we have seen in trials that you can't track, it can't reliably expect a sentinel lymph node to drain, and then do post-mastectomy radiation. And so just helping people get guideline concordant care would improve overall survival for inflammatory breast cancer really significantly.
Right. Are you getting to the end of your list, Jennifer? I know
Yes,
you had all kinds of things.
oh no, I've got more. The next one I was just trying to figure out, like, fund research and clinical trials. Like, how will this impact that? Will it impact it? Will it make it easier? Will it make it easier for researchers? What
I
is
think
that?
that's the piece that'll take a little time. The simplest research that's done with ICD-10 codes is to be able to pull it out of these national databases and ask incidents, outcomes, where are the gaps, what do we need to do about it? So I think those things will come, but I think they're, again, going to take some time as the use and uptake happens.
So it will be years before we see major changes, correct?
I
As
think that's true, but I think we'll see a real momentum around it. And maybe people will think of ways that it can be utilized sooner to kind of drive change. But I think we're all still kind of figuring out, how do we get that message out? How do we really enhance and expand it? How do we reach people with that information? and make sure it's moving forward.
Question is it, I've seen conflicting things. And I know you said, Dr. Woodward, you wanted to mention something about how this happened. So I'm gonna let you run with that. But also, is this or is this not an international code? I've heard two different things, and you were on the committee.
Yeah, well, it's I wish I knew more about this than I did. I realize it's a gap in my knowledge. And so for sure, I have talked with, I just recently was a part of an IBC educational panel at ESMO Breast. And the colleague from the NKI said, oh, if only there were ICD-10 codes. So it's clearly international. They are international diagnosis codes. That piece is absolutely true. What I don't have a great understanding for is how exactly is it used. It's certainly not billing in a country that has national healthcare, right? Like you're not billing for healthcare in England in the same way that we bill for it here. But national health registries are places where we see amazing national data that you can look at the entire national group of women who have breast cancer, who have this, and pull all that data out. So maybe in a country that has a national healthcare system that is using their diagnosis codes and immediately changes to use the correct diagnosis code, you get there faster, right? Maybe in 3 years, the Netherlands is going to have 3 years worth of data that they can pull out of their national registry. I don't know that for sure, and I've sent some feelers out to colleagues who can educate me on it, but my sense is that we will be able to see some real legitimate worldwide impact, but I'm still gathering information, and anyone who's watching can add some notes to the chat and correct me.
Well, and I'm sure there's, did you want to talk about how this came to be? I know you said there's something you wanted to say about that.
Well, just what we said at the beginning, that I think one thing that I was interested in hearing from Komen is that a big part of it is that the time was right, that a lot of the work that many people have contributed to in pulling people together, creating the IBC score, validating that, having some of this knowledge of how policy works, helped to make it clear. I think I really suspect that having the data that guideline concordant care is not being followed was very helpful. And you could say, okay, well, how did we get that data if you need a code to have the data? In these national databases, you can pull out inflammatory breast cancer if someone has correctly used the correct staging. So inflammatory breast cancer T stage is T4D, D as in dog, and it is the only T stage that is inflammatory breast cancer. And so if someone has correctly used that T stage, that's how we pull it out of our national databases now. You cannot tie it to billing, which is going to be related to a billing code. And that will be a future state where people who do a lot of this kind of analysis can actually take insurance billing databases and connect them to tumor registry databases, and then be able to say, oh, everyone who had this, now I can tell you had a lumpectomy, had something like that. So the quality of the data, the type of data that's reported, you begin to be able to pull from different places because of the code.
I'm going to see what questions Jennifer has to want to wrap up. And I know you've got a pretty long list, but I know Dr. Woodward has got a really busy schedule. I was talking the other day and she says she answers about 500 emails on average. I don't know a day. I don't know how you guys do it. So when someone says they're crazy busy, I always laugh and said, no, you need to meet some of these doctors. They're crazy busy. But I'm taking notes because I want to see if we can do a survey to put in San Antonio next year. And maybe, if it was appropriate for us to consider an article, or maybe the people on these committees could do the article. I'm over taking lots of notes of where we
Awesome.
can get this going further. But Jennifer, how do you want to wrap this up as far as a few more questions? Or how do you feel about this as somebody in this world that's lived this, as a patient? I mean, Dr. Woodward was your doctor.
Yes, 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 yes. I traveled down to Texas to see Dr. Woodward for my radiation, and she was amazing. And I'm very grateful. I think she was a big part of why I'm here today. So I'm very grateful to Dr. Woodward and all her work.
Thank you so much. That's so nice. And I think for me, what I would say is that I think that this is just an enormous opportunity. I think that it is fantastic to see some real milestones be hit in the inflammatory breast cancer community. It galvanizes the momentum, but it also prompts a lot of questions. It opens the door to new things that we can do and pursue. And I think that's really exciting.
What can I do as a former patient to help others? What can we do, not in the medical field? What can I do to help move this forward?
I think some of what you guys do that's so valuable is connecting to patients who are newly diagnosed, helping them to know what guideline concordant care is, helping them to appreciate the value of advocating for themselves. And in doing that, knowing that they have a code that they could ask and say, hey, did you know this? Because patients with IBC are the best source of education for physicians. And I say that knowing no patient wants to have to educate their physician on how to be a doctor or do their medical practice. That's not the piece. But the things that you know about what's going on in the advocacy community, that it's there for them, that there are all of these resources. Physicians value that. We're grateful when somebody comes in and knows, about sort of the landscape in a space we might not know. And I think that's something that you guys do really well, is to help patients know what's out there so that they can help their teams know.
I'm convinced that this is not rare. I know they say if you buy a red car, you see red cars. But the other day I was talking to Diane Costner, who lives up in Davenport, Iowa, and she lost her daughter to IBC, and she started this wonderful organization called Lindsay's Legacy to help pay for travel for people to go to specialty care. But she said her next door neighbor's niece was diagnosed with inflammatory breast cancer. And she said, and so I know I've beat this drum so forever, but I'm convinced it's not as rare as they think. And that is
I'm
something I'm
sure
very
it's
excited about.
underdiagnosed. I have no doubt. And one challenge about the code is that if you don't recognize IBC, you won't code it as IBC. So that's still a diagnosis problem. Diagnosing it is hard. First, you have to make a diagnosis of cancer in a woman who looks like they have mastitis, and everybody wants everybody to have mastitis. That's a very natural thing. It's more common. So you've got to get all of the right diagnostics and biopsies to make the diagnosis. And then amongst patients who have cancer, with breast cancer, you have to distinguish, is it IBC or not? And I think until you've done that, you can't pick the right code. So we still have that education to do. And because not everyone has classic looking textbook IBC, it's a little bit hard. And I think not every patient I see who I truly believe has IBC has a clear redness. People with different skin tones may have different things. Sometimes it's just a weird thing. You could have so much skin thickening that you can see on an image, like a centimeter of skin that's just clearly edematous, which is an absolute flag for IBC, but the skin doesn't look that different. And so people are like, well, it doesn't look that red, so that can't be what it is. So that piece is educational. I've heard people say, yeah, that looks exactly like IBC, but she has so many lymph nodes, it's just congested. We'll brush that off because, it is probably attributed to something else. So I think that piece, that educational piece is still really there. But if somebody can make the diagnosis, at least you can track it. And that should increase our awareness of what people are seeing. And as we help people make the diagnosis, we'll see, I think, that it's underdiagnosed.
So too, Jennifer, you got a burning parting question, or I don't want to cut you
No.
off too soon, but I know Dr. Woodward's got a very demanding schedule, and I'm always
Yes,
grateful for her generosity to meet with us.
thank you.
Thank you.
I don't have any more questions.
Well, thank you
I think we did
guys
a
for
great
doing
job.
this. Yeah, great job. And I'm so appreciative of all that you do, and the support that you provide patients and researchers and all of those things is really just incredible. You've had a huge impact.
Well, I want to thank Dr. Wendy Woodward. She is the executive director of the Morgan Welch Clinic for Inflammatory Breast Cancer at MD Anderson. She's also one of the most published people on IBC radiation, which I think is really an exciting thing to know. And Jennifer Heckert is here with us, who is in Ohio, and she's also was a patient of Dr. Woodward, you heard earlier. And she's also one of our board members from Ohio, and I'm very grateful that she took the time to do this podcast with us. And I see so much hope. And that's how I want to end this. So again, thank you for being with us. And we can't wait to talk again when there's more things to share about this.
Awesome. Cheers, everybody. Thank you.
Thank you.